Welcome back, everyone. Just a few announcements before I introduce our afternoon speaker. Immediately after the session this afternoon, there will be a poster reception with drinks and canapes. There are going to be a number of chaired sessions happening throughout the reception, so it would be great if all the poster presenters could attend to be around to present their findings. All posters can also be viewed on the forum website after the event or by those who are visiting virtually. And also a final announcement, 5 breakfast sessions tomorrow for those of you who are early starters, 7:45 a.m. to 8:45 a.m. You need to sign up at the registration desk. The breakfast sessions I have listed here are Achieving Breakthrough Improvement in Hospitals, presented by A.T. Kearney. This sounds like the Oscars, doesn't it? Patient-Reported Outcomes, the NHS programme starts delivering, presented by Bupa. Global Comparators, Leading Hospitals, Leading Quality, presented by Dr. Foster Intelligence. Improving Patient Safety and Quality of Care, the Role of Innovative Medical Technology, presented by Medtronic. Tobacco Dependence, a Medical Condition or a Lifestyle Choice, presented by Pfizer. And finally, an IHI breakfast session, the details of which you can find at the main desk. So, to our speaker today. Any of you who were at the Science Symposium on Tuesday will have heard Charles Vincent talk very interestingly about what patient safety research can learn from climate change research. It was a fascinating comparison, and I think caused many people to rethink some of the challenges that patient safety research is facing. And if you want to read the article that Charles Vincent and colleagues have written, it's in the supplement to BMJ Quality and Safety, the April supplement, which is freely available online. If you Google it or go to the BMJ Quality and Safety Journal online, you'll find the full supplement there, a very interesting article. But this session is on climate change itself, arguably the greatest threat to patient and indeed public safety that we currently face. And I know of no one better to talk about it than our speaker today. David Pencheon is a public health doctor. He is the founding director of the NHS Sustainable Development Unit, which is one of the few organisations of its type in the world. It develops organisations, people, tools and policy to help the NHS in England be a leading sustainable and low-carbon organisation. I'm sure we all have a lot to learn from his talk. Over to you, David.
Thank you. Okay, thank you very much indeed, Fiona. It's a great privilege to be here, just as a delegate, actually. It's an even bigger privilege, an honour to be speaking with you. But what will be the greatest privilege will be to listen to some of the things, the responses, the way you might be minded to engage in what we're going to discuss, what I'm going to talk to you for in the next few minutes. And unusually for a session like this, for a keynote, we're going to try and do some questions at the end. But I'll be around after this, so if you want to advise me or give me some feedback about the work we're doing in England, then I'd be more than delighted. Anyway, so we're going to talk a little bit about a journey we've been on in the NHS. Some of us have been on for many, many years, if not decades. And the vision is very clear. The vision is, and it's central to safety and quality in healthcare. And that is, how do we deliver high-quality healthcare in a way today that does not prejudice our ability to deliver the same high quality or even better tomorrow? And really from Gro Harlem Brundtland's report about what sustainable development is, slightly ugly phrase, but when you think about it, it's exactly right. It's about development that meets the needs of the present without compromising the abilities of others in the future. And I've added here, or elsewhere now, because climate change is not a future issue. It is a very current, present issue for many people around the world. We are all privileged in this world to be insulated. We're robust enough as individuals or communities to be insulated from many of the effects, but that's only a short-term thing. We have a duty. We have a duty of care for tomorrow. So the other thing I should preface this talk by is that sustainability here is really combining environmental sustainability and weaving it with financial sustainability and social sustainability. Interestingly, a couple of years ago, there was a conference in Copenhagen, a climate change conference. I don't know if any of you missed it, but a lot of countries sent delegates there. And in my role in the NHS in England, I had to advise people who, the ministers and negotiators who went from England. And there was a very chilling story, a very chilling thing that one of them told me. And a senior person who told me, he said, you know, it's interesting, in going to Copenhagen, we've been advised and lobbied and approached by every civic and professional group that we've ever heard of, except one group that's been notably silent about this. Can I just invite you to guess which group has been very silent about climate change? It's health professionals. Health professionals, bar some very notable exceptions, have been remarkably quiet. Just ask yourself this question. What is it about us as people who work in the healthcare sector and the public health system that has actually made us paradoxically quiet about this? Now, I have some theories of my own, but I would love to hear from you. There are some very compelling hypotheses. We're very busy. We've got incredibly busy day jobs. Climate change is not our core business. But the one that really worries me is the one where we say, I spend my whole day and night saving patients. You want me to save the planet as well? Now, people have said that to me, but I think it's something that underpins that, which is we already do good things. We already do good things. Let someone else cope with this big issue. But really, let me tell you that it wasn't until health professionals started addressing other issues like tobacco that the wider society took these things seriously. So it's really, really important. I do believe we have a duty of care. Not drop everything else you're doing, climate change is the new kid on the block. It's absolutely not that. And as I'll hope to demonstrate, many of the things we would want to do to develop a more sustainable healthcare system do bring now benefits for patients and staff and the public now. Co-benefits, and unless we reframe those benefits in compelling ways to our colleagues, we're never going to get there. So, these are the things I'm going to hope to talk about. Why is sustainability and climate change central? What are the opportunities if we act now, and what are the threats if we don't? What is the evidence, and crucially, how do we reframe it? So this talk is really about large-scale change. What should we be doing now? Because we do need to be doing some things now, the little things and the big things. And most importantly, and this is where I would really value your input, is how do we engage people? How do we reframe this? How do we make it a core part of the values of healthcare system? How do we make it a core part of the delivery process? So that's a tricky one. So anyway, one of the things we did was we went round and talked to some of the biggest thought leaders in England and around the world who approached us and said, listen, I think this is a really important issue, and I don't know much about it, I don't understand climate change really, you know, my partner's a skeptic, but I think there's something in it for high-quality, safe healthcare. And one of the questions I ask all of these people is, why do you get engaged? Why have you asked me? And there are about 5 reasons that come out, and it's really interesting about, you'll know the evidence about large-scale change, is you have to reframe issues in ways that connect with the values of the people you're trying to engage. Universal rule of large-scale change. But just so you know, in terms of this sort of research, this is what came out. Why do people get engaged? Well, you can guess the first one. It's money. It'll save you money here and now, and more money that we can reinvest in direct patient care. The second is the legal, regulatory and reporting framework. There's nothing more motivates a chief executive than to say to them, I'm afraid you're breaking the law. So, you know, use laws. Laws, they're a good thing. And we're lucky in the UK that we do have a Climate Change Act. We're one of the few countries that legislate it. And interestingly, later this year, we have a carbon tax in the UK. And large UK hospitals are going to be in publicly declared league tables about their carbon footprint. So the future has already arrived. It's just a little unevenly distributed. So we're going to find that increasingly common amongst all of us. So it's worthwhile remembering that's not a bad way to reframe things. reputation, responsibility, duty and example. And this applies both to organisations and individuals. I do believe as a health professional that we do have a duty of care. What is the point of delivering high quality care today if we know that the way we do it is jeopardising our ability and the ability of others to deliver that high quality tomorrow? It's just, it's not acceptable. We have no right to do that. Safety, quality and resilience, well, people who do emergency planning, and you've seen things already today about Japan. I think it was this time last year that we had the ash cloud. Stuff happens. And one of the things about large-scale change, one of the most successful stories about large-scale change, are those people who are ready for change when the rest of the world is ready. So having plans up your sleeve. We are not going to convince people to change because I think it's a good idea, but they don't or you don't. It's being ready for people when they're ready, and that's very, very important. And fifthly, and this always comes, the health word often comes very low on this, about health protection, health improvement and social justice. And I just wanted to say a little bit about, later on, about social justice, the obligations we have not just to generations in the future, in time, but in space. People around the world who are suffering now because of the way we choose to live. And I think there's a very profound ethical issue there. So, one of the things is always get someone important to try and write something. So this is a note. We got Chris Huhn as the Secretary of State for Energy and Climate Change in the UK government, and Andrew Lansley as the Secretary of State for Health. So get them to write something together, and more importantly, hold them to it. So this is something that they've written, and like all these things that politicians write, I think they're very scared that one day someone will come back and say, you wrote this, and so what are you actually doing about it? Just one of the things that is part of large-scale change. Secondly, get the academic community involved. Why? Because there are so many things we do not know. We simply don't know what is the best way to do. We don't even know whether, for instance, delivering patient care through a telephone line, non-face-to-face, we don't know how much it costs. We don't really know much about whether it's acceptable. So we have lots of visions of what a healthcare and a low-carbon future could look like, but we don't know some of the details, and we absolutely have to invest a lot of money in the research, and I'll show you a little bit about that in a second. So, and we all know, I mean, this is the usual climate change story. We all know that climate change causes illness and deaths from, cataracts and vector-borne diseases and skin cancer. When it comes on to things like flooding and heat waves, these are system changes, these are societal changes. We're not so good at those. I think as health professionals, we love the disease. We love the sort of, hey, it's a crisis, someone's ill, get in there, do an intervention, get them better, next please. We're very much of that mindset, and that's a mindset that's not particularly useful for looking at really long-term health issues like climate change and the benefits that sustainable development have to offer. I often think that one of our biggest problems is that we're a bunch of crisis junkies. We love crises. I mean, I went to medical school because I just loved blue lights and, drama and out of the way, I'm a doctor. But actually, we know that high-quality healthcare is not delivered like that. So, one of the things about large-scale change is understanding the mindsets of those of us in this room today, who, all of us, including myself, who we nearly need to readdress it. But, of course, this is not how climate change kills. You know that. Climate change kills globally through crop failure, through drought, through economic collapse, through migration, through civil disorder. And the last slide, well, if you don't know what that slide is, then you know what that slide is, that last picture? Easter Island, a microcosm, absolute perfect microcosm of sleepwalking into a nightmare. And as Pete Postlethwaite says in one of his films, it's not that we do this, it's not that we tread this path, it's that we tread it knowingly. That is the interesting thing. I mean, I often think about Martians circulating the globe, looking down on us and thinking, wow, there are two really spooky things about this carbon-based life form. One is that there are amazing disparities of health and opportunity globally. You can pick up a mobile phone from anywhere in the world to anywhere else in the world. So it is a global village. But the disparities in health and opportunity are really pretty obscene. And the other thing that's bizarre is 200 years ago, they discovered this black sticky stuff on which all life in the wealthy part of the world depends, absolutely addicted to it. God, if you think heroin's addictive, try carbon. It's absolutely extraordinary. And one day they will discover what the byproducts, what the toxic side effects of having such a carbon-based existence is. They will discover this, and boy, will they get their game together to sort it out. Anyway, they land and they open a copy of Washington Post or Le Monde, and they think, my goodness, they already know what they're doing. Isn't that extraordinary? So one of the interesting things about large-scale change is this really important human phenomenon, one of the most important coping mechanisms we've got, both individually and as groups, which is the coping mechanism we call denial. It's fantastically useful. It's very useful. It gets us all through the day. It gets us all through our busy day, denial. But there are some situations in which it's very counterproductive, and perhaps this is one of them. Anyway, so we know the data. We know that in, for instance, 2003, I was talking to WHO last week, and they said it's not 30,000, it's probably about 75,000 in Europe. But what happened with policy in Europe? Actually, very little. And, you know, I'm always reminded of that Stalinist phrase that one death is a tragedy. And we've heard some wonderful narrative-based things. And you heard Atul at lunchtime, many of you, talking about one person in Texas, named person, in a road traffic accident, not getting pneumococcal vaccine. Very powerful narrative. One person's death or one person's misfortune is a tragedy, 10 is a disaster, 30,000 is a statistic. It's incredibly important to try and reframe these things that make them real. Before I was a doctor, I was a mathematics teacher, and one of the things I came to learn very quickly is most of us, even intelligent people, don't understand numbers greater than about 30. If you can't see, you can't hold 30 oranges in your, it's difficult. It's very tricky. So just be careful how we use large numbers. We're just not framed to do it. So we know a lot of the research. We know exactly what's going on, but you see, ignoring evidence is unsafe. And one of the interesting things about climate change is that it's happening at a very inconvenient rate. It's happening slow enough for us to sort of ignore it or adapt to it, but fast enough for it to be very, very seriously dangerous. So it's very much like the frog in the boiling water. Boil the water slowly and the frog stays in the water. Boil it quickly, drop it in, it'll jump out. It's happening to us slowly enough for us to do far too little about it. But now I'm going to change tack completely, because I don't think we need to talk about climate change at all. And I'm not going to try and avoid talking about it completely for the rest of the time unless you challenge me at the end. And the reason being is this. There's a very, very positive future, regardless of climate change happening or not, if we use resources much more judiciously. If we do many of the things that all of us in this room have been trying to do, which is to promote things like high quality, safe, dignified, compassionate, humane healthcare. This is part of this picture. Don't get obsessed by climate change. There's another reason for not getting obsessed by climate change, is because it's boring and it's scary. So don't take people on that journey unless you necessarily have to. So it's just one tool in the toolbox. So there is a much better world for high-quality healthcare, which completely aligns with a sustainable world. And I'll just take you through that, about what is the better world, what is the evidence, and how has it been made real and practical within the world of healthcare. And I really think that an audience like this, which takes safety and quality very seriously, I still think we take it seriously for the short term. So I want to go through what has come to be known as health co-benefits. And these health co-benefits happen at 3 levels. So taking the future very seriously in terms of what does healthcare look like in a sustainable, low-carbon world? Well, if you start drawing vignettes and scenarios and visions of a low-carbon world, we'll know that we'll do things really quite differently in our lifestyles. 2 of them are we'll probably eat differently and we'll probably move differently. It is a paradox that we move around the world more than we've ever moved before, but we move our bodies less. But in a world where we are much more physically active, we have a much better diet, we'll have much better improved mental health, less road trauma, less air pollution, less obesity. There's a very synergistic, compelling co-benefit argument. That's just for people. And it's a lot about moving care upstream. It's about a mindset where let's assume that any unplanned admission to a hospital is a sign of system failure somewhere in the world. It's that sort of mindset. So that moves us into what it looks like for a healthcare system where we have much more prevention, it's much more financially sustainable, more care closer to home, more empowered self-care. As we heard this morning, people talking about using the public as the most important resource we've got. Much better use of IT. Why is it that many, many years ago we could go around the world and put our cash card into almost any teller machine in the world and access our bank account? Why can we not do that in healthcare? Well, it's just extraordinary what laggards we are. In the most knowledge-rich business in the world, we don't carry our health information. The person, we know that better care is delivered when you're holding your own. You're the only person who knows everything about your own drugs, your own disease. Why we haven't engaged with that better. So it's about better models of care. Of course, it is about things like procurement, using energy in hospitals. It's all that sort of stuff. But transformational change is about better models of care that suit everybody. And thirdly, and briefly, I do want to touch on the global fairness, social justice, because this is another way of reframing this issue. And the best example of that was produced in 2009 as a cartogram in The Lancet as part of this series. Here you'll see a cartogram where the countries are in the shape of who produces greenhouse gases, and that's a fairly easy calculation to do, and who bears the burden in terms of climate change and mortality. Now go back to that one and then go to that one. That's just not fair. We have absolutely no right to do this. It's not a question, it's not a technological issue, it's just an ethical or moral issue. And it makes it very challenging for us to see our way forward in terms of global agreements. So, what have we done in the NHS? Well, we've done very little with a team of about 5 people for 3 years. The first thing we've done is to measure. That old edict about measure it and manage it. Well, the first thing we did was the largest scope 1, 2, 3 carbon footprint of any organisation in the world. The NHS is a large organisation, 3rd or 4th biggest in the world. It has the carbon footprint of a medium-sized country. Delivering healthcare is a high-carbon business, and it may well be carbon really well spent, but it may not be. Just like we don't spend money well, we probably don't spend carbon well. So it's got a very, very big carbon footprint. So where is that carbon footprint? Well, we had to analyse that as well. But what we did first was we drew some very compelling visions of what healthcare looks like in 2030 in a low-carbon world. It'll either be a low-carbon world or it'll be a no world. So this is not an option. It's how we get to a low-carbon world. So we measured the carbon footprint, and what we found was that the vast majority of it is in procurement. Some of it's in travel, some of it's in building energy use, but it's what we buy and use and nearly always dispose of badly that has such an environmental impact. And nearly all of that saves money. So when you talk about waste in health services, it's not just black bags outside the back of operating theatres. It's about wasted processes, wasted models of care, wasted pathways of care. So where is that procurement, which is an interesting question? Well, about 1/3 of it is in pharmaceuticals. Pharmaceuticals do fantastically good things for our health, but they are very high carbon products. So we have to be very clear that we're using it. Is yet another reason to use pharmaceuticals very, very carefully and judiciously. So none of this makes us do anything differently. It just reminds us that there's yet another reason to do this stuff really well. So where do we need to be? Well, that blue line on the left here, over here, that's where, up here, this is where the NHS has come in terms of carbon footprint. And you see where we need to be by 2050 to comply with legally mandated targets. This is the law. And I know you may look at that and you may think, my goodness, this looks like one of those cartoons that says, and a miracle happens here. But the truth is, we know how to do these things. We've done some of the calculations. We know that some of the really compelling, patient-centered, high-quality, safe models of care are low carbon. So there's a win-win here. When I talk to my colleagues from other big companies in the world, like General Electric or Timberland or Marks & Spencer's, they say to me, and these are real gurus in sustainable development and what the world looks like in a low-carbon future. They're not talking about incremental change. They're talking about transformational change. So when Philips talks about washing machines, they don't just talk about how they make it a little bit more energy efficient. They talk about how they're going to help make clothes that need washing less. They talk about things like washing without water. So when Marks & Spencer's talks about making suits for people, it's not about selling suits, it's providing a service for suits. Have 2 suits, bring 1 back. Bring them all back, we'll give you some more. It's moving, and this is a real mantra of a low-carbon world, and it's very relevant for the healthcare system. It's moving from products to services. And that's what the retail sector is. We're going to stop delivering products. There, it's mine, give me some money and I'll give it to you. It's about providing services. And we already in the healthcare business flatter ourselves that we provide services. We often talk about patient pathways. Anybody ever felt they've been on a patient pathway? It feels like spaghetti to most people. There are models of care. So, when we say pathways, be careful, because we've had this model of, sick person, start on the pathway, and they're better again. And we know that's simply not true with long-term conditions, with multiple conditions. So we have a lot to learn from the private sector. And of course, one of the things that always makes me laugh, they say to me, God, it must be great working in the healthcare sector because all your incentives are aligned for a sustainable world. All your colleagues in the healthcare sector must be really up for this. It absolutely plays to your core strengths, your core methods of delivery, your core values. It must be great in the health. Come and meet my colleagues in the healthcare system. Of all the, and I'm not the only person. There are medical journal editors who have probably suffered the outrageous arrows of misfortune by saying things in public about this and getting really quite heavily criticised by members of their own profession. This is not our core business. Get back in your surgery. Concentrate on the sick person in front of you. So, interesting, isn't it? Methinks they do complain too much. So there is a very big issue about how we take on board this really big issue. And we don't need more big issues to take on board, but just remember that some of these things absolutely play to our core values, but it's a real challenge and it's going to be a really long journey. So about 6 months ago, we embarked on quite a big consultation process with people, some thought leaders around the world, about what are we going to need to do in healthcare systems to make them sustainable. Not sustainable in the sense of being durable, doing the same thing, same wrong thing again and again and again, but sustainable in the fact that we are doing it in a way that allows future generations to do it as well, as high quality. And what's interesting, this is 6 months of research distilled onto 1 slide, so that's a mean task. There seem to be 3 large strands, and this is very concordant with large-scale change. There are 3 things we need to address. One is behaviours of organisations, behaviours of individuals. The second is around standards. By that, that's a short term for governance, regulation, rules, expectations. And the third is about innovation. And by innovation, I don't necessarily just mean bits of kit. I don't mean technology in terms of whizzy things we can measure blood sugar so that people with diabetes can stay at home. It's about innovation in terms of really transformational changes in models of care. So hospitals without beds and beds without hospitals, those sorts of really big changes. To give you an example, to give people some sort of hope and faith in the future, I just thought I'd include this slide, which some of you may have seen before. I'm a bit worried about which North African country I put this slide in. But there are 2 red squares you see there. The small red square is the area of North Africa you would need to cover in very well-proven solar technology to provide carbon-free electricity for the whole of Europe. And the large one, these are large areas, by the way, they look small, they're rather large. The large one is how much we would need to cover the Sahara in to provide carbon-free electricity for the whole of the world. The whole of the world, not at present population, but at the population it's likely to stabilise at in a couple of decades around the 9.5, 10 billion mark. Is this possible? Do we know how to do this? We know absolutely how to do this. It's been worked out almost to the last detail. Who paid for it? We paid for it because it's a European Union-sponsored huge piece of research about how does Europe lead the world into a low-carbon future. What's stopping it? Is it technology? No. It's about the politics of how we transport energy around a grid around the world, about whose energy is going across whose country, and are we resilient, and are we in some way susceptible to their whims. Not that we've got a particularly stable energy system now, I have to say. Let's compare it with something real. So that's just to give you some faith in the fact that a lot of people in other sectors other than the healthcare sector are thinking very, very much about what the world looks like for them in a low-carbon world. The military forces, armies and navies and air forces around the world have got very ambitious plans for how they provide national security in a low-carbon world. I just think in the healthcare sector we could do a lot better. It absolutely plays to the values and the work of many of us in this room. Anyway, the value changes, and this is really a distillation, although we published it, is very much what we, I've only been in the conference 24 hours, and nearly all of these value changes I've heard at one time or other in many of the sessions I've been to since I've been here, since yesterday afternoon. So there's some really important value changes going on in the healthcare system, but we have to make sure they go on in ways that are sustainable, both environmentally, financially, and socially. So just to finish off, how is it making its way into mainstream quality and safety world? Well, here's a paper from the Royal College of Physicians defining quality, and there are lots of papers like this. This is at the end of last year, 2010, and what you'll see is these sort of pillars of quality are very familiar to you, but what's been added in is sustainability. And it's not just a sort of another me on the block. It's not a sort of, oh, me too. Something's very interesting about this sustainability as a core dimension of quality. And it was alerted to me by someone called Donald Donoghue, who's the National Clinical Director for Kidney Services in England. And this is what he said, which is absolutely perfect. If you look at all, and you all being quality gurus in this room, you'll know this, that nearly all the dimensions of quality are in some way compete against each other. They're sort of trade-offs. Yes, wouldn't it be great to have a trauma centre on every street corner? But, you know, it's not going to happen, okay? But the interesting thing about sustainability is that it actually supports nearly every other dimension of quality. It doesn't get into this trade-off of, oh, it's effective but it's not timely, oh, it's patient-centred but it's not terribly equitable. It supports nearly every other dimension of quality. And it's not just through leaders like Donald O'Donoghue who've led this, and the people that he's inspired and funded to actually operationalise it. So if you want to see some really good examples of, you know, renal services is a high carbon, you'll know they're high carbon intensive, very techie things. So if you want to talk to someone who's really thought through some of these things, including how we involve patients genuinely in their own care, then come and talk to a kidney doctor in England. There's one down in the front row here I'll introduce you to afterwards. And it's not just the physicians, the Royal College of General Practitioners. You may know that there's a big sort of, as Bernard Crump said this morning in one of the sessions, you know, this change that's visible from the outer space. It's not true. You can't see it from outer space. In the way the NHS is changing. Embedding it in principles of high-quality commission is very, very important. So I think we have a duty of care. We have every opportunity to align incentives, everything from financial sustainability all the way through to aligning it with the values of professionals. This is large-scale change at its very best. And now that I've told you this, and now that some of you, this may be new information, you can't forget it. It's lumbered with you. You've got an opportunity to either try very hard to deny it or think through and talk to your colleagues about what it means for how we evolve high-quality, safe services. There's a real role for international leadership in this. We had a workshop near Cambridge last week, and I just spread it around a few emails. It was incredibly highly oversubscribed. International leaders in healthcare wanting to understand what difference this makes for high-quality healthcare in the future. So in summary, I think that climate change is undoubtedly a huge threat to health. The evidence does warrant action. And it's about incremental, it's about transformational, but it's also around disruptive change. Disruption will happen. Be ready for disruption. There will be plenty of things that are going to happen that are unplanned and unforecast, and change will happen best by those of us who are prepared for it. Is central to safety and quality in healthcare, and it will be increasingly so. We can reap multiple benefits for health and healthcare if we choose to. And finally, it is happening on our watch, and it will be our legacy. Okay, thank you very much.
I'm just reading your cartoon. Thank you very much, David. Now, we have some microphones, I'm told. And the idea is that if you'd like to ask David a question, and he'd really like to hear your questions, there's one. And is there another one? There's one. So the microphones are going to stand still, and you'll need to move to them, because we're all about moving more from now on. Our bodies, that is. So please do find a microphone if you'd like to ask a question.
I can wait.
Large-scale change. I can see... David, you've stunned them all. David, can I ask while people are getting their thoughts together? Oh, there's a question. Marvellous. I have a question later.
Hello.
Could you say who you are, please?
Yeah, my name's Amma. I'm actually a junior paediatrics trainee from England, from Luton. I just wanted to ask, one subject that's quite close to my heart is child obesity, and that obviously all ties in nicely. Any words of advice or encouragement in terms of going about, from where I am, tackling this problem in the future?
That's a great... I mean, all these things are heavily interconnected. I mean, if you are interested, I'd recommend you read a book by Professor Ian Roberts called The Energy Glut, which he very compellingly brings together some of the great issues of our time and reframes some of them that we think of as problems as solutions. So eating, lack of physical activity, obesity. You know, he'll come up to you and he'll grab that bit there. Okay, and he said, "That's fossil fuel, mate. That's fossil fuel there." It is. I mean, what's really interesting about obesity is, of course, that everybody in this room is obese. I think every single person in this room, well, let's say overweight. It's that, you know, you don't need to know much about a normal distribution to see how we're renormalizing what we consider to be a normal BMI. It's very interesting. I mean, do you remember this morning when we heard about, I think we heard Maureen say, you know, this obesity epidemic has happened in my son's lifetime. Do you remember that? Did you remember? Okay. That's not true. That's not really true. Actually, it's happened over a longer period than that, because if you think of a normal distribution moving, a normal distribution can move quite a long way while the thin bit is moving, and then suddenly it gets steep, and suddenly you get this absolutely, you know, what you see with young kids. And it's been happening a long, long time. And I only say that because what are people going to say 20 years hence when they think back and think, God, these guys knew climate change was happening, and they did absolutely naff all about it. So change is often needed a long time before we actually get round to it. We often need crises to make it change. We often need a non-linear event. And believe me, non-linear events kill people. They kill people. King's Cross Fire killed people before we had the political gumption and leadership and courage to ban tobacco in enclosed spaces on the London tube system. Well, we don't want to do that with climate change. So let's appeal to the rational side of our lives as much as the emotional side of our lives, and have a little bit of joined-up thinking and more importantly, joined-up action. Yeah, they're very cleverly linked, but the challenge for you and me is to communicate it. Is not to say, oh, it's not climate change, it's obesity. That's more important. You know, this is a nightmare, and you know how the media carved the tobacco lobby to bits by saying, oh, we're still not quite sure about it. And you can see it's fascinating the way the media and the climate skeptics. It's just a microcosm of what happened in the tobacco world. We're reliving it all over again. You know, those who don't learn from history are destined to repeat it.
Question over here. Oh, I was also looking for Charles Vincent, since I mentioned him earlier. Is he here in the room? Can I?
There's someone down here as well.
He's gone. Other questions?
You mentioned earlier, my name is Gil Milikovsky. I'm a member of the IHI, Patient Safety Activist Group. You mentioned to motivate money is one way to do so, and you assume that what changed the anti-tobacco movement is the involvement of physicians. That's
one of the things.
That's not what happened. What happened is when Medicare in the United States...
a question, please, if you could?
Well, how do you explain it?
No, a question is what I asked.
Question, do you agree that it's the fact that Medicare expenses from lung cancer is what really made rethinking the US government and suddenly became interested in restriction of tobacco use?
David?
I don't know. I mean, I'm free to that. I don't know the answer to that question. But what I do know is that it only takes good people to do nothing for bad things to happen. And we would all like to think we're good people. So I think when we see physicians, when we see health professionals taking issues seriously, people take action. And I'll tell you the rationale on which that is done. Every single person in this room has bizarre habits of which we are not proud of, whether it's buying hundreds of shoes or something else even more unpleasant. How do we rationalize that? Well, we're just so fantastically clever at rationalizing our bizarre behavior, such as, oh, I've got to go for a job interview, or, oh, it's going to rain next week. Now, one of the bizarre habits we have is live in a completely unsustainable way. And I think one of the ways in which we justify, or the general public justifies being part of corporate delusion, is to look at people like, now, who are the most trustworthy people in most Western countries? Fact. Who is the most trustworthy section of the population trustworthy? Doctors. Okay? So when people look at doctors and see doctors driving 400 yards in a 4x4 and saying in public media that climate change is rubbish, now that does send out a bizarre message. But it also sends out a very strongly affirmatory message to those people who think, I'd rather not believe the evidence, because we're not rational beings. So I think we have a duty, we have a profound duty of care. And it's not instead of something else, it's part of the way we do business. It's a core value of healthcare systems. If private organisations can make staggering leaps towards a low-carbon world, then can't we do it?
David, on that very challenging note, may I thank you very much for a wonderful talk. And now the poster session. Enjoy. Thank you.